The kind of DMEK surgeries that scare me, the surgeries where I feel like I'm not sure that this operation is possible or that I can do this surgery, are the cases with the extremely shallow anterior chamber. The reason is that if you've got an eye with a deep chamber that's post-vitrectomy, that's got a scleral fixated lens or an ACIOL, those can be frustrating. They can be annoying. They can be difficult to unfold the graft because the graft is spinning around, but those cases are always possible. However, if you've got a slit anterior chamber with simply no space between the back of the cornea and the front of the iris, sometimes those cases are literally impossible. If there's no room to unfold the graft, if there's no space, you can't do the surgery. So those are the cases that I worry about. And when I see those patients, that's when I start to get concerned. And of course, the patients that manifest this condition, the slit anterior chamber, are the ones with the deranged anterior segments, with scar tissue and loose zonules and iris issues, the disaster train wreck eyes. Those are the operations that I worry about. And there's a patient that I want to share with you, a patient that I operated on last week in our office just 6 days ago. And I want to show her video and talk to you about why it scared me so bad and what we did to make the operation successful. This is this lady's only eye. And the condition of her only eye here is light perception. We're doing the surgery in my office under topical anesthesia using only oral Valium. And I'm starting by trying to make some paracenteses. And that maneuver is frustrated because you can see the iris is sucked up against the back of this cornea. So normally what I do is use an AC maintainer with air for a decimeterexis, but initially I'm just trying to deepen the chamber with a cyclodialysis spatula and an AC maintainer connected to fluid. And when you're looking into the eye, past and through the cornea, into the anterior chamber, your visibility is better with fluid. So that's why I break those synechia with my cyclodialysis spatula with fluid. And now with that long, aggressive, inverted Sinskey hook, I'm peeling this thick, scarified retrocorneal membrane from the back surface of the patient's cornea, and I'm walking around using different paracenteses to peel it from its various point of attachment. And once I've freed up this giant wad of scar tissue, then I make a new main incision directly temporally with a steel keratome, reach inside the eye, and peel out this retrocorneal membrane. And once that's done, I'm evaluating now the depth of the anterior chamber. How deep is the AC? Because if the chamber isn't deep, I won't be able to unfold the graft. You can see here the chamber is not deep peripherally despite all of these maneuvers because the bubble doesn't go all the way out peripherally. So I'm sweeping around with the inverted Sinskey again and with the cyclodialysis spatula, and still you'll notice, especially inferiorly, the bubble just doesn't go all the way out to the periphery. The chamber is intractably shallow. So what to do? Well, one key insight that has occurred to me over the years of doing these operations is you can deepen the chamber by debulking the space behind the lens. If you remove vitreous, then the lens and the iris diaphragm fall backward, which deepen the chamber. So that's what I'm doing here. I make a supranasal peritomy, and then with a mini crescent knife, I make a triangular partial thickness scleral flap, just like I'm doing a trabeculectomy. And I make it about 50% depth, and then right at the base of that flap with a 21 gauge needle, I make a sclerostomy, and then into this sclerostomy, I stick my vitrectomy handpiece, and I do a dry core vitrectomy with no infusion to soften the eye and to debulk the space behind the lens and the iris. And this trick alone has been enormously helpful. There are some eyes that you cannot deepen the chamber on unless you're willing to do a vitrectomy. So people out there who don't do DMEK in vitrectomized eyes, you have to learn, because there are some eyes that can only be done if you yourself vitrectomize them. So having done that, things are better, but you'll notice I still have these anterior synechia. The whole iris is moving and shifting under this cyclodialysis spatula. So the key tip number 2 is I use these micro-coaxial scissors to directly cut these peripheral anterior synechia. And this is the other critical tip that took me so long to learn. I used to think you could break these synechial adhesions by sweeping. You can't. They're tenacious. The scar tissue is stronger than the iris tissue. You have to cut them so then you can peel them out, which is what I'm doing now. And having done that, you'll notice the bubble now extends all the way out into the periphery. This is a truly much deeper anterior chamber facilitated by cutting those synechia with microcoaxial scissors and doing a core vitrectomy. I'm getting ready to put the DMEK graft into the anterior chamber, and so I debride the corneal epithelium, because this is the stage where I want to maximize my visibility. And you'll notice it's actually not so bad. I can see pretty well what I'm doing here, and the challenge that I'm going to have to deal with the graft inside the eye is going to be still a cramped, shallow anterior chamber that is unstable. This is an unstable anterior chamber because this eye has got large iris defects. There's a tube shunt in the pars plana. That's that nubbin up there, supratemporal. That's the scleral patch graft over the tube shunt. This eye's got zonual problems. So this is an eye with an unwieldy, unstable, cramped anterior chamber. How do you deal with the graft in that situation? Well, you'll notice a couple things before I even insert the tissue. First is the graft is stained vibrantly, brilliantly blue. That's because I always restain the graft right before I'm going to inject it in these complicated eyes, because the surgery is difficult enough. If you expect you might have trouble unfolding the tissue, you really want that graft stained as well as possible so you can see what's going on. So I always personally restain the graft before doing these really complicated cases. The other thing is that I have selected a graft size which is intentionally small and a graft age which is intentionally advanced, which is to say I'm using a 7.5 millimeter graft from a donor 70 years old or older. And I specify smaller grafts in these tight, cramped anterior chambers and older donors when I can get it, so the graft is more loosely curled and easier to unscroll. Now, this has been an edited video, of course, but as always, when it comes to graft unfolding, we're going to let it roll with no edits. Okay, so here's the graft injected into the anterior chamber. The eye is soft, and I reach in and initially aspirate that bubble. That's always step 1, is remove the bubble, which competes with me for control over the tissue. And as I do that, as I remove these bubbles, I'm looking down at the graft to try to see what is its orientation. This is an ill-defined single roll. There's one edge kind of flapped over the other. I can't tell if it's right side up or upside down. So I'm doing my normal trick. I'm irrigating the eye into the anterior chamber to see if I can agitate the graft, to get the graft to flip and perk up and open up so I can see what's going on. There, I thought it was right side up, so I tried checking the Motsuro sign. It was negative. The graft was upside down. So I'm trying to irrigate and flip the tissue, but it's sort of wanting to turn into this vaguely tacoed origami configuration in which it's not just folded over once, but it's double folded. And when you have a double folded graft, it's really difficult to unfold with taps. And the key to getting the graft into a solvable configuration is to deepen the chamber. You need room in between the back of the cornea and the front of the iris so you can get these edges to open away from each other. So that's what I'm doing, not trying to squirt at the graft per se, but rather to deepen the chamber so the graft can unfold. And here I'm coming from multiple different vantage points, and it's tough. This is tricky. The graft is unwieldy. There's not room for the edges to open up. Now here, it looks like maybe I'm making some progress, and I'm going to look down into the anterior chamber, and temporarily over here by me, I think I can see vaguely the outline of the orientation mark, which is pointing counterclockwise, which means the graft is upside down. So I'm trying to flip it. I'm irrigating underneath the graft as I depress the paracentesis to see if I can get the graft to flip over. The orientation mark is still pointing counterclockwise, so it's still upside down, but I persist. And as I do that, the graft flips right side up. And that was the key to solving this operation, this graft configuration, was to recognize the upside down configuration and then how to solve it, which is to say by irrigating perpendicular to the lie of the graft while depressing the wound. Here I'm going through the main wound to perform the help yourself technique. I know the graft is right side up, so I'm moving the graft over to center it in the eye, and I'm poking it over and open into the angle. And you'll notice the eye is soft and collapsed because this is basically a unicameral eye because of all of the zonular issues that these eyes with tube shunts have. And I'm just persisting in this help yourself maneuver to center the tissue and to open the edges. And this is by far more effective and efficient than taps on the corneal surface or even bubbles to open these edges. It's direct touching, but it's often the only effective way to open these stubborn, persistent folds. Now the graft is mostly unfolded, so the tip now is to try to lift it with an air bubble. So I apply an air bubble. The graft is mostly lifted, but the bubble is a bit large, so I'm shrinking it. But I remove too much of the bubble, or some of it disappears posterior to the iris. So I have to try again. And here what I'm doing is I'm just once again physically centering and moving the graft over into a more normal configuration, more normal location. And the bubble pops back up from below the iris diaphragm. So this is what I mean by an unstable anterior chamber. You have things coming and going from the front and the back surface of the eye. You don't have control over the anterior chamber. And that's why it's useful to directly manipulate the tissue with the cannula. Here the graft seems all the way open and unfolded and relatively centered, so I'm going to lift it with an air bubble directly underneath the tissue through the main wound, again using these long cannulas, which I so prefer over the short little measly stubbly ones that don't reach all the way across the eye. And this is it. This is the eye at the end of the operation. So this was a very fun surgery. It's one that I really enjoyed doing. I mean, the operations I like the most are the most challenging ones, the ones where you feel like it's a real test and you're pushing yourself to try to get better and do better. And the key for me to be able to do this operation was, number one, to try to deepen the chamber. That's the most important thing, is you cannot unfold the graft if the chamber is shallow. And how did we deepen the chamber? It was synechialysis using a cyclodialysis spatula, followed by core vitrectomy, followed by cutting the remaining synechia with coaxial micro scissors. The coaxial micro scissors, I cannot explain how important that was, because you cannot break these synechial adhesions with blunt dissection. The scar tissue is more tenacious than the iris tissue. You'll rip the iris out by the root and cause horrific bleeding. You've got to cut the scar tissue with scissors if you want to deepen the chamber. And if you can't deepen the chamber, you can't unfold the graft. And even if you could, you wouldn't be able to keep an air bubble in there to support the tissue afterwards. So deepening the chamber with dissection and scissors and vitrectomy, those were the key things during the surgery to make the unfolding possible. And then before the surgery, I set myself up for success by staining the graft brilliantly blue right before I injected it, and by using a small graft from an aged donor. If you do those things, I think you will find your next anterior chamber shallow, cramped, nightmare, disaster DMEKs to be much more pleasant and possible. If you have any tips that I should be doing If you've got some insight that you can teach me, leave it in the comments. Teach me how to do the operation better along with everybody else watching. Thanks so much.